for the Clinical Consultation Network. As you know, we do this every Tuesday at 1:30 p.m. Central Time. And today we've got a great guest. Her name is Lillian Darnell, and she is the behavior analyst for the Middle Tennessee Mental Health Institute, as well as the forensics unit of the Middle Tennessee Mental Health Institute. So she's going to tell us a little bit about her services today, and so I'm very glad to have her. She's a great partner. One of the things she's going to talk about a little bit later is a program that she and Michelle have been putting together for us to go around the state and talk to the folks at the Mental Health Institute, try to get them some more information about people with intellectual and developmental disabilities and behavior services. And so that's something we have planned that I think is going to benefit everybody. It's going to get people on the mental health side to know us just a little bit better, and also for them to know our population a little bit better, and to know maybe more about how to intervene, how to help us when we need it, and how we can also help them. So it's, I think, a good plan that we have for that, and so I'm looking forward to that. And Lily, I just want to welcome you. I'm glad to have you here today. You are certainly one of the kind of central people over on the mental health side that we can connect with and that can be helpful to us. And so I wanted to, before we launch into the presentation, just get you to introduce yourself a little bit and tell us a little bit about yourself.
Sure. Well, thank you. My name is Lily Darnell, and like Dr. Davis said, I'm the behavior analyst at Middle Tennessee Mental Health Institute. I was born in Kentucky, but lived in Florida, so I went to undergrad at the University of Florida, and then I did my master's at University of Maryland, Baltimore County, and worked at the Kennedy Krieger Institute, and then I came to Tennessee. I just recently got married last year, a little bit more than a year ago, and we just adopted a new baby puppy that I love very, very much, and he's the best. So, yes, that's a little bit about myself.
Okay, what's his name, and what breed of dog?
He is, the rescue thinks he's like a poodle mix.
Okay.
He's just this little white fluff ball, and his name is Arlo.
Arlo, okay. All right.
Yeah.
That's good. And
he'll be on December 20th. So really looking forward to having a birthday party for him because I'm that person.
Oh, okay. You give birthday parties for dogs.
Yeah.
That's a good person to be. Okay. Now, you also did some work in dementia before, right?
Yes.
Some other time I want to get you to come on and talk about dementia, because we had a presentation about that a few weeks ago, and I would really love for you to come back on sometime and talk about some of the work you've done in dementia. But today you're going to talk to us about behavior services at Middle Tennessee Mental Health Institute. And I'm going to kind of back out and let you kind of roll with it, although I might stop you periodically just to ask a question or two.
Yeah, no problem. That sounds great. So, hello everyone, and good afternoon. So today I will be presenting at the behavior services that I offer at Middle Tennessee Mental Health Institute, and also just give a kind of overview of our hospital, and so people have more of an idea of what goes on here. So to begin, Middle Tennessee Mental Health Institute, or MTMHI, we are the largest mental health institute in the state of Tennessee. We currently serve 18 counties throughout Middle Tennessee, whereas the Forensic Services Program, or FSP, which I'll talk a little bit more in a bit, we serve the entire state. So there is a total of 207 beds here, which is subdivided into 3 short-term units. Those are called our Acute Treatment Programs, or ATP. 4 long-term units called Extended Treatment Programs, or ETP. And then the Forensic Services Program is called FSP, and we have 2 units within the Forensic Services Program, the Evaluation Unit and the Treatment Unit, and I'll go into depth about each of these.
So, Lily, let me ask you a question right off the kick up there. So the other regional mental health institutes they are regional though, but you're not a regional mental health institute. You serve the entire state. Am I understanding you correctly?
So we have two separate sort of facilities. The main hospital, or MTMHI, with the ATP and ETP units, we only serve those 18 counties. Whereas the Forensic Services Program, which we are still considered part of Middle Tennessee Mental Health Institute, but we're in a separate building, we serve the entire state, so we can get patients from all across the state.
I missed the Forensic Services Program part of that sentence. Yeah. Thank you very much.
No worries. So, like I was saying, we are the only maximum security facility in the state. FSP is. At FSP, there are 30 beds total, but they are subdivided into a treatment unit, which max capacity is 18, and then an evaluation unit, which is max capacity 12. So I think it's important here to stress that we are a treatment facility, so even though it is a maximum security facility, our patients aren't in cells. We don't utilize cells. They have free access to the unit just like on our other units.
And if you're about to go into this, that's good. But I was just going to ask about the difference between the treatment unit and the evaluation unit. How do they work together, or how do you determine who goes into which program?
Yes. So I'll start with treatment because we all reside at the Forensic Services Program, both units, but they are very different. So treatment patients engage in behavior that's considered too severe to be managed at other regional mental health institutes. So, for example, if someone was considered too violent, and they're at Moccasin Bend Mental Health Institute, and they're too violent and they need a maximum security setting, they could be transferred to our main, to FSP. Typically, we see the patients that are on our treatment unit. They engage in multiple assaults on patients and staff, and all of these placements must be pre-approved by the authorization of the Commissioner of Mental Health. So these patients, it's kind of a misnomer, even though we're at a Forensic Services Program, the majority of these patients on our treatment unit don't have any active legal charges.
I see.
We also do have patients on our treatment unit that are coming in from jail for continued treatment and training. To get into statute, they would be considered 301Bs, which basically means that they've already had their evaluation, but they need additional time or training in order to be considered competent or to get additional information to the court. So we do have patients that might be here for continuous competency training, but they are still very violent, so they reside on our treatment unit. Now, typically our treatment patients, they do have dual diagnoses. Personality disorders are often prevalent after the psychosis is treated. And some of our patients can have various degrees of cognitive impairment. It's important to note that we see the question that I normally often get is, like, what's the most common diagnosis for your FSP treatment patients? And it would be probably schizophrenia, paranoid schizophrenia. We also see a lot of antisocial personality disorder here. It's very treatment-resistant mental illnesses.
When you say dual diagnosis, are you speaking only of IDD and or cognitive disability and a mental health disorder, or are you speaking of maybe other dual diagnoses that exist, like substance abuse and mental health disorders? So you're speaking more broadly about dual diagnosis, or are you speaking specifically about substance abuse?
We see a lot of substance abuse and remission by just the fact that they're in a controlled environment. We see a lot of times dual diagnoses of a personality disorder and then an overarching psychosis.
Gotcha.
We typically don't have individuals with intellectual disabilities. Or if it is, it's just a suspected traumatic brain injury. That's been also a common one here.
Sure.
So that's our treatment unit, where our evaluation unit, these are patients that are currently, they are jail inmates. So they have been sent to the maximum security facility for a forensic evaluation. Now, this has to be court ordered, so we receive the court order that allows them to come to our facility. We pick them up from jail drops them off here, and then they are patients of FSP. These court-ordered forensic evaluations are typically looking for competency to stand trial, and or if they have grounds for the insanity defense. So to get more technical, these patients on our evaluation side are considered 301As, and we have 30 days to complete the evaluation, and then they would return to jail for the next step of their process.
So, Lily, when you say a 301A, that's the section of the Tennessee Code annotated that addresses or allows them to be ordered into the facility and then defines the period of their evaluation, right?
Yes.
Right in that?
Yes, you are right.
Okay.
It's like 301A, or there's like all these other numbers. But
I know. I understand.
So it's important to stress that rehospitalization for these patients is common. So we have had many cases where jails will send their patients here for a forensic evaluation, and while they are patients at our facility, the charges against them are dropped, but they still meet commitment criteria, because if they are found to be a risk of harm to themselves or a risk of harm to others. So at times their charges can be dropped mid-evaluation, and then they turn into a Code 51, which just basically means that they're still meeting commitment criteria. So our evaluation unit patients, typically, they are highly dangerous and violent while in jail. Thus, they need a inpatient court-ordered forensic evaluation. Just to compare, if someone was requiring a forensic evaluation while in jail, an outpatient provider would go and see them at the jail and evaluate them, and if they can complete their evaluation, then great, super, but if they are considered to be too violent or engage in behavior that might be indicative of malingering, then we will get a court order to have them evaluated at our inpatient unit, at FSP eval. A lot of times these patients are also considered flight risks, because we see a lot of patients with very serious charges against them, like rape, first-degree murder. They are facing long periods of time in prison, so at times they need to be sent to the maximum secure facility to reduce the likelihood that they are going to leave or try to escape. So I want to stress that all of our state-run psychiatric hospitals can and do forensic evaluations. but patients are placed at FSP due to either the severity of their behavior in jail or the severity of their charges. And that's why we will get patients from all across the state.
And then persons with IDD who are committable end up going to Earl Jordan Center in our forensic assessment unit there. So that's just to kind of fill in the gap for those people who have IDD.
Exactly. Yes. So, we had a pretty substantial behavior program that's available for treatment patients at FSP. I get the question, why is it only for treatment patients? Well, we have it only for treatment patients because it would be too risky to expand this to our eval patients. A lot of times we will get eval patients that are feigning symptoms of mental illness in order to hopefully receive less charges or less time. A lot of them enjoy being at FSP, so we are not looking to shape up that behavior.
Yeah. And you see this program that you have in place as something that they might like. I mean, it would be a plus for them to have that.
Right. It'd be a welcome change. And we're not looking to, we want to have them have a smooth transition back to jail since our eval patients would be going back to jail at the completion of their evaluation. Okay. So, this behavior program for the treatment patients at FSP, it was first implemented in 2017. It is a multi-component program. We utilized antecedent measures, operational definitions, which, a lot of us are obviously very familiar with. But again, here at MTVHI, it's a pretty strong medical model. So really getting kind of those ADA basics and ADA 101 is one of the cornerstones of the program, because operational definitions were really stressed with staff and nurses, so we can all know that we're talking about the same thing when we're identifying behaviors. We utilize social extinction and or planned ignoring, and also utilize differential reinforcement of other and alternative behavior. And I'm going to go a little bit more in depth into this. So with the behavior program, we utilize individual contingencies and daily randomized reinforcers for appropriate behavior and participation, because we are offering treatment groups to our patients here. We are a treatment facility. We're not a jail. So we really are trying to encourage participation in those groups. We do not utilize group contingencies here because there would be an extremely high likelihood for retaliatory behavior if a group reinforcer was not earned. So those are not utilized. In addition to the comprehensive behavior program, some patients that either engage in high severity or high frequency maladaptive behavior, also I will create individualized behavior support plans in addition to the overarching behavior program. And we have a few patients at FSP on individualized behavior plans.
So when you say they have individual contingencies, you've identified reinforcers for the individuals, but it fits into kind of a general program. And then in certain circumstances, you got to do an individualized one.
That's exactly right. Yep. So to talk a little bit more about the individual contingencies, we offer commissary and yes.
Sorry, I just wanted to interrupt. We had a chat question. They want to know to what extent you use functional analysis or assessment technologies, and what are the barriers and revelations you've encountered?
Great question. So we don't do formal FAs here. But as far as a functional behavior assessment, that's completed for all individuals on individualized plans, behavior plans. There's a formal functional behavior assessment. The remaining patients, typically, I like to describe it as the patients at FSP treatment, they all engage in maladaptive behavior that's warranting them coming here. But if it's to the point that they're not responding to this overarching program or the medication provided, then we would look more closer, and then I would be consulted to do an individualized behavior assessment on them. So it's kind of everyone's treated on an individualized basis. Does that get to your question?
So it sounds like you kind of use the general program, and then eventually,
yes,
if need be, you're going to look into it deeper and do a more thorough assessment.
Yes, exactly. So with the individual contingencies, people are, you're welcome. If you're saying you're welcome. Okay, so
we're telling thank you. That's our friend Nikki Jonas from Knoxville.
So I always like to stress that it's not commissary in the traditional sense. Our only currency is good behavior, or really, to be more technical, the absence of inappropriate behavior. So if a patient doesn't engage in target behaviors, which we have a whole list of operational definitions, or require the use of seclusion or 4-point restraints, then they are allowed to attend commissary each week. We have a wide assortment of items available in commissary. So we have frozen food, ice cream, snacks, coffee, as well as higher quality toiletries. I will state this a little bit later, but we are a lockdown facility, so our patients are not going out into the community. So these items are essentially make it much more higher and reinforced in value. Right. So typically, you go from Wednesday after commissary to the Wednesday before commissary, and they receive access to commissary on Wednesday. The question is, I get a lot is, how many things can they get in commissary? It's a stock 4 items. So any 4 items that they want, we give them the autonomy to choose what items they want. If there's a specialized item that they would like they really love Flaming Hot Cheetos, which everyone loves for some reason, they can request that, and we can make accommodations to get an item. We're just really trying to have appropriate behavior. Then from the Wednesday after commissary to the Friday before bingo is always played on Friday. Patients can have access to bingo with prizes. So what I also state to the patients is that everyone's permitted to play, but few are permitted to win, in the sense that everyone will be allowed to play because it's a therapeutic activity, but you have to have good behavior in order to collect prizes, and everyone wins a prize. So that has broken up the week a bit, and it's worked extremely well.
What kinds of prizes do they win in that?
At bingo?
Yeah.
At bingo, it's literally just smaller quantities of commissary food or specialized items. So a lot of times it's like chips, soda, snack cakes, stuff like that, and they just get lesser amounts.
Okay.
So the FSP program in totality has been extremely effective. It's resulted in substantial decreased rates of target behavior. We have an increasing rate of step downs. It's important to note that if you are a patient at our FSP treatment side, you will never be discharged directly back into the community. we do a step-down process to a lesser secure facility, rather, it be up on the hill at our main hospital or to another regional mental health facility if that's where they came from. So that's always our goal, is to get them out of this most restrictive setting into a lesser restrictive setting where they can have access to more things. So we are set to surpass last year's number of transfers. We're at 14 currently, whoop whoop, so that's very exciting, and we're very happy about that. We also offer some other variables that we think are responsible for the effectiveness of the program. It is a highly structured program, and we have seen that these patients who engage in severe problem behavior respond extremely well when things are very structured and very concrete. I had to really work to change the culture of FSP. Prior, we would see that staff were using foods and sodas and stuff to essentially bribe patients into being good on their shifts, and it was a very toxic environment. And we as behavior analysts know, and just know in general, that this is only going to breed more maladaptive behavior. So really, it was about changing the mindset of staff members that have been working here.
Did they have any kind of system in place there that was supposed to be implemented, or that wasn't being implemented maybe at the time that you changed when you came there, or was there just no structure at all?
Yeah, there was this really super confusing process where people would earn points contingent on attending groups, but someone could, engage in physical aggression, but they had 50 points, so you still got to use your points. And then it was this really, really convoluted, rollover system. So sometimes, on commissary day, you would have people banking 20 sodas and, 5 bags of chips. So I'm exaggerating, but it would be a lot of items. And there was a lot to keep up with in terms of staff-wise. You had to keep up with their points and subtracting points, and it was just very convoluted. And then also, for our patients that have severe treatment-resistant mental health, and then also have all these other factors going on, like they've been in and out of prison, or they've been in and out of institutions, it was very hard for a patient to understand what they needed to do.
Yeah. We got another question here, and so this is coming from one of your brothers at Moccasin Bend, Johnny Payne. He's asked, how did you get frontline shift staff to get on board with the behavioral interventions? What was effective in changing thinking for staff? Because I think what you're trying to answer is changing the culture of FSP question, but take off a little bit on what Johnny asked there.
Sure. Really, it was first, from my end, just rapport building. So understanding that this is what they were doing in order to get by and to go home safely to their family. So really working on that rapport. And then what we do now is stressing to them that we do front-end sort of education. So I have a new employee orientation training that, puts it out there like we don't allow contraband. This is not allowed. And also another big part of it was really getting administration to also agree and be supportive. So administration is completely on board. Nursing executives, these sort of things, they really support and believe in the behavior program and its utility. So stressing that with them, and then we all do know that patients or that staff respond to consequences. So we do say on the front end during our new employee orientation that if you are found giving contraband, that you could face disciplinary action. So it's a disciplinary. I try to break it down in the training that, you know, when you give patients contraband, you're placing yourself at risk, but you're also placing your coworkers at risk, and making it into more tangible sort of examples so they can see, oh, it might just seem like one soda here or there, but it really creates a whole set of problems. So just really working on that training and education piece.
Yeah, that seems really important. And does it become part of their individual performance plan?
I believe so. I think I can't speak to that just because I don't know.
You don't.
But I believe. So yes, again, we have no contraband in our facility. This, of course, makes a higher reinforcing value of items available in commissary. So it's really driving that point home that you cannot bring in contraband, explaining what contraband is, and kind of going through all the scenarios that could happen if you were giving contraband. So some other variables responsible for the effectiveness. We have other therapeutic measures available at FSP, so we try to have a robust environmental enrichment package in order to help our patients. So some of those therapeutic measures include our treatment patients have non-contingent access to a sensory room. We would see that we would have patients engage in severe maladaptive behavior in order to get access to the seclusion room or 4-point restraints because they would just want to be alone, or, you know, they found something reinforcing about being by themselves in that room. So we have now a sensory room which is far more aesthetically pleasing than a seclusion room in that there's a calming videos, music, it's painted a nice color, it has a different floor, and those sort of things that we have had a lot of success with, because patients, if they just need to get away from, you know, the day rooms or need to be by themselves and they want something a little bit calming, or they just want to get away for a bit, they have non-contingent access to that sensory room by themselves. So there's no staff that has to be observing them in the terms of like standing there one-on-one, and they also, it's on an individualized basis, so you would just go in there by yourself. You're not going to have to share that room with 3 other patients. We have a garden that patients help tend. This is a picture from it in the spring, and it's very rewarding to see patients be so proud of something that they have planted, that they have helped take care of, pulled weeds at. So at the end of the season, we pull out all the vegetables and we create it into a little salad for them, and we serve it to them, you know, during their meals. And it's very reinforcing to the patients to be proud of something. A lot of these patients, even though they have engaged in severe problem behavior, they've had very traumatic histories, very severe things happen in their lives that have led them to this facility. So giving them something more, you know, appropriate and rewarding has been very enriching to them, it seems. We have a library also that they can go to on site, of course. We have certain rules for, you know, you can't have 10 books in your possession, but they can go to the library. So if anyone out there has any soft cover books or magazines that they would like to donate, please let me know. I'll put my name on at the end, but we're always looking for new reading material for them. We also have a ceramics studio here, so our patients can go and pick out a ceramic and paint it. It's the same sort of theory with the garden. So they can't keep ceramics in their room once they've completed them. But the ceramic room is always very popular this time of year because they can paint things and our staff will then put it through the kiln and glaze it for them. And then they can send it to family members or people out in the community that's on their contact list. And they like to do that for Christmas, for presents and whatnot.
That wasn't me.
That wasn't me. I'm not presenting for the best. But all these things are really to stress that we are a treatment facility. We're not a jail. We are really striving to meet the treatment needs of these very complex patients and provide them care and support so they can eventually be transferred to less restrictive settings and then eventually be transferred back out into the community to be successful. We are a fluid program with input from other disciplines, so we have a treatment team here. In treatment team, we have the psychiatrist, psychologist, nursing, medical, social worker, treatment team coordinator, recreational therapist, and me, the behavior analyst.
So thinking about those different folks, what's the role of the psychologist and the social worker in this setting?
Oh, okay. So our psychologist is typically on board if they are receiving any one-on-one therapy, individualized sessions. Our psychologist is there to work on any continued competency or forensic evaluations if they're 301B. She works with the 301As. So that's typically the role of the psychologist. The social worker, she's like the go-to person to coordinate visits. A lot of times they're requesting additional information from other facilities. If they are 301B patients, then they are communicating with like the arresting officers, requesting records of the affidavits, things like that. They're kind of, the cornerstone of assisting patients to get what they need as well as assisting to get information to the treatment team.
Is that Dr. Easton? Is that your psychologist? I forgot.
Yes, Dr. Rena Eiston, yes.
Eiston.
Yes, she is our psychologist, and she is wonderful. We also have input from our direct care staff. They're called psychiatric technicians here. They provide extremely valuable input about how the program is working because I like to stress that this program is a fluid program. It's constantly changing and open to suggestions, so that's really, really valuable when our direct care staff have that input. So, some other behavioral services provided, we have acute treatment programs here. That's 3 units, and these are patients with acute mental health needs that need treatment and stabilization. So the average length of stay for these patients is anywhere from 3 to 7 days. It's very transient on these units, very fast-paced, and again, those ACP units are serving the entire Middle Tennessee community. So at the acute treatment program, I will provide information regarding staff instruction. So I like to stress that behavior support plans are not implemented on the acute unit mainly because of sheer impracticality. We have close to 600 staff members that work in the hospital, so it is near impossible to have a very large-scale programmatic behavior plan in place on the acute unit. So typically, what we will do is I will do staff instructions, which are just very informal guidelines of things that might help a patient and be implemented only with staff, so modifying staff behavior. On the acute programs, we are coordinating with the NCOs, the ECF program, DIDs if they are a DIDs member, and coordinating services with patients who lack community support. So from a behavior service side, we will often get patients with intellectual or developmental disabilities on our acute unit that have no resources in the community. They're not part of DIDs, they're not part of ECS, they may not even have insurance. So we really work to try to set things up for these patients so to prevent the rehospitalization of them, but also so they can be successful in the community.
And you know something, Lily, it's an interesting fact to a lot of people that there are actually a lot more of those people than there are people who are in services.
Yeah, I believe it.
And so I always say the folks on the mental health side know a lot about our population because they work with them on a basis.
Yes, definitely. Definitely. So some things that we can do to help facilitate these services, our practitioners can write a prescription for ABA services in-house, and a lot of times this can just be simple in that it reduces them to have to go see a PCP to get services set up. If they are in ECS, another way we can do this is we can try to coordinate if this person desperately needs a behavior analyst. We will work with the NCOs to get a behavior analyst identified so there's a more seamless transition from the inpatient hospital out to ADA services rather than be on a waiting list for months. We also will do recommendations for other services, and also I'll assist with finding appropriate housing and long-term placement for these individuals. So some other services provided on the ETP units, those are extended treatment. That's 4 units, and these are for patients with severe chronic and or treatment-resistant mental illness. The average length of stay for these patients is undetermined. We have had patients on our ETP units for as little as 30 days, upwards to 30-plus years. It just depends on each individual. So also I will implement staff instructions on the ETP units, and then also, if warranted, do individual functional behavior assessments with a resulting function-based behavior support plan. So because these services are so labor-intensive, they're reserved for the extended treatment program as well as the FSP treatment patients.
So these are folks on the extended treatment program where you have more of an opportunity to do a thorough assessment and really dig into the treatment because they're there for an extended period of time.
Exactly. And more than often, it's more appropriate for me to provide services because they live here. They are residing here, and it's more stable. So I will reserve those spots to the extended treatment program patients as well as the FSP treatment patients.
And I forgot what the numbers were, the number of units that you have, but are there more extended treatment folks at MTMHS, or are there more acute?
There are more extended treatment programs in terms of units. We have 4 extended and 3 acute, but there are obviously far more patients on the acute because they're in and out all the time. Right. But yeah. So also here, I do a hospital-wide training for staff detailing patients with intellectual and developmental disabilities because our staff are very good at working with patients with mental health needs, but it can be a little more foreign for them for patients with an intellectual disability or autism spectrum disorder. So additionally, I will do training on new employee orientation for patients with special needs as well as the FSP behavior program. So because we have close to 600 staff members, there's just a constant, every 2 weeks we have new employee orientation. Additionally, I will provide on-site consultation with other regional mental health facilities. So I frequently go to Memphis Mental Health Institute to provide services for their patients with intellectual or developmental disabilities. For 2020, what we have planned is I'm going to have some additional training for new employee orientation. Dr. Eisen and I will have a presentation on appropriate staff-to-patient boundaries, and also I will be implementing a quality behavior support for patients, so kind of like ABA 101. Additionally, we're set to have a partnership with DIS, so Michelle and Dr. Davis, to do a statewide training at each regional mental health facility for providing care to the IDDD population. And then we are set to have a phase 2, which is having additional training to subsets in the community like first responders, law enforcement, medical professionals, where it's all a big work in progress, but we're really, really excited about it.
Yeah, I'm excited about it too. I can't wait for us to get going on that because I think it'll do a lot. If nothing else, when you do training like that, it helps build relationships, and I think that's a key thing that we need here for this business.
Agreed. So I like to put in here for community VAs that are on the call. So what we could get from community VAs is if there's really pertinent information that you want shared, to contact the patient's treatment team. Your best bet would be the social worker. And if there are pertinent needs that need to be shared that could help, I really appreciate when VAs have something that they want to share and they kind of let our treatment team know. It can be difficult to get those numbers, but hopefully maybe I can be a good contact for people moving forward. If there are any updates to the crisis plan that your individual that you might be serving has, that would be very helpful to have. And then when would I contact a community VA? I will, if there are very high, severe need individuals that come in or individuals that are frequently readmitted. This is to help determine what is working in the community, what is not working, and if there's anything we can do on our end to help facilitate something working. Also, if further coordination for crisis support is needed. In sum, I like to be transparent, but it can be extremely difficult for patients with intellectual and developmental disabilities when at NTMHI. The majority of the patients on our acute unit are neurotypical with severe mental health needs. They might be experiencing active psychosis or engaging in some sort of other mental episode crisis. So it can be very scary and overwhelming for a patient with special needs when they're here. And we really strive to do the best we can to provide care and get them back out into the community as safely and as quickly as possible. Like what I just said.
You're saying it's not the ideal place for a person with IDD to get their treatment.
It is not.
Yeah.
It is not the most ideal. And, my goal and what I strive to is to provide as much expertise and assistance as possible to current and future patients that I serve, either whether they have an intellectual disability or not. So if there's any more questions, please let me know. And this is my contact info. I am more than happy to assist any way possible for patients that might come in or anything like that. So Please let me know if there's any questions. I'm more than happy to share.
Yeah, Lily is a great resource, and I do encourage you to write her information down and contact her. You might even contact her just if you want to discuss a case or something, have a little about somebody who's being admitted even to one of the other mental health institutes. I think it should be a great resource for that. And I think that moving forward, you know, that it is good if you have somebody who's getting admitted to MTMHI to contact Lily and just kind of discuss the case a little bit, provide whatever information you have. Your functional assessment is something I think that might be really valuable to Lily, trying to understand what it is that you found is a function of the behavior, and then I think that sets the stage for more successful treatment in the community when they come back out. So it's I think it's really great. I really appreciate you coming on and talking to us about all this today, Lily. And
well, thank you for having me.
Especially putting your name and number down here and your email address and everything so people can contact you. Does anybody else out there have any other questions that you want to come on and ask, or you want to type it in the chat box, Ken, or you can just unmute yourself and come on and ask a question?
If there's anything I can provide more clarification on too, just let me know. There's a lot of moving parts here at MTMHI.
Yeah, your information about how the Forensic Services Program operates is really helpful, I think, to a lot of people. And one of these days soon, I'm going to do the same thing for the Forensic Assessment Unit at Harold Jordan Center, because I think there's a lot of misunderstanding about that. So, I really appreciate you coming on today. You're a great partner, as is Department of Mental Health, and so this is Clinical Consultation Network. We do this every Tuesday at 1:30. Actually, though, I did put in today's notice we're going to shift to 12:30 Central Time beginning January 7th. Next week we're going to go ahead and meet at 1:30 as we have previously, but on January 7th we're shifting over to 12:30 Central Time. We're not going to have a Clinical Consultation Network on Christmas Eve or New Year's Eve. So we will give you a couple of weeks off from Clinical Consultation Network after next week and get started in the new year. And thanks again, Lily, for being here. You're a wonderful partner, and we just look forward to working with you more in the future.
Yes, thank you so much. Me too. Thank you for having me.
All right. Thank you, everybody. Bye-bye.
Thanks. Bye.